Good afternoon, and welcome to Reducing 30-Day Readmissions with Smooth Transitions of Care, a complimentary webinar from HealthSystemCIO.com, sponsored by McKesson. A little housekeeping before we get going. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com. I'll be your moderator today. We encourage questions. You can send them in at any time by typing them into the Q&A box in the lower right-hand corner of your screen. Leave the default set to all panelists. You can send them in at any time, and we'll take them later in the program. I sent the URL out in the chat box. You can see it in front of you, and there's a shortened URL at the bottom of each slide for the deck, so you can access the slides that way. And we'll have an archive of this event ready within 2 business days. You'll receive an email when it's ready, and a separate registration is required. A little change in our lineup today. Craig Richardville was unable to make the event at the last moment, so one of his trusty lieutenants, Dwayne McNeil, Assistant VP of IS with Carolina's HealthCare System, is going to be delivering the presentation. We're looking forward to that. Then we'll get a word from our sponsor, from Deborah Bulger, VP of Product Marketing at McKesson, and then we'll have our Q&A with Dwayne. So without further delay, I'm going to turn it over to Dwayne McNeil. Dwayne? Thanks for joining us.
Thank you, Anthony. It's my pleasure to be with the group today. There are several topics that we will cover. I'll give you a quick introduction to Carolina's healthcare system. We'll cover the readmissions background as a general topic. We'll talk a little bit about how we apply analytics to readmissions and some of our results and our next steps and current focus. And then we'll take the Q&A. About Carolina's healthcare, the key point on this slide, this is one of our traditional marketing slides, but the key points I'd like to highlight are our total enterprise size. And we have 900 plus care locations. These include hospitals. These are owned, leased, and managed facilities. We have more than 180 primary care practices. We have surgical rehab centers. We have home health agencies, nursing homes, hospice, palliative care, LTAC. We have the entire spectrum. This presents some interesting opportunities as well as challenges as we talk about readmissions. We also have over 2,500 employed physicians in the total enterprise, 15,000 plus nurses, and 60,000 plus teammates or employees. And over 11 million patient encounters each year. These are a lot of touch points with the patients that we serve and present a lot of opportunities. A quick slide about information services team that I'm a part of. The key point on this is most of our IS services are centralized. There are a few exceptions for our regional colleagues, but most of the technology services are out of our Charlotte, North Carolina Information Services group. Some background on readmissions and the imperative that generated. To take us back in time, there were multiple reports to Congress and published research in the mid-2000 range that highlighted avoidable readmissions as a target to eliminate waste. The percentages and financial amount were significant. And the publications have various different numbers, but this was one of the key numbers. 18% of Medicare patients discharged from the hospital have a readmission within 30 days of discharge. And we're talking about perceived avoidable readmission to the hospital and accounting for $15 billion. And once again, this was just in Medicare. And some of the numbers published in 2009 have it closer to 20 million for that number. So readmissions is not a new topic or concern, even prior to the attention it received. But the result was new focus on readmissions in the form of some of the initiatives listed to the right, such as the Pay for Performance programs. All these points are obvious to the healthcare organizations. The contracting that you do, this comes into play. One of the key components is the avoiding readmission penalties that we'll talk a little bit more about. The public benchmarking and public reporting that became part of the equation, and certainly the focus on high cost of health care nationally. On the readmissions imperative, let's talk about the CMS Hospital Readmission Reduction Program. This was one of the key drivers of some of the attention that's gone into it. The overall objectives: improve quality, reduce cost, and I won't try to take us into all of the details of the program, but I will say, I'll highlight that there were 3 conditions with excess readmission penalties that applied as of 2013, and the penalties increased from 1% in 2013 to 3% starting in 2015. These were for performance periods that are sliding back in time. So for 2013 penalties, we were looking at a performance period of 2008 to 2011. And as we look forward to 2015, we're looking at a performance period of 2010 to 2013. Also, we have a couple of new additions to the mix for 2015, and that's COPD and elective hip and knee. And not featured on this slide, we have another addition coming in 2017, the coronary artery bypass graft procedures. So with the national attention and potential impact on our healthcare system, the readmissions received added attention within Carolina's healthcare. Local facility efforts were already in place for process and quality improvements around readmissions. However, the system-level attention was focused on analyzing the situation and focusing on our internal efforts on the large opportunities. To bring us up to date on some of our topic today and some of the areas that we've targeted over the past couple of years, awareness and education has been a major focus. Identification of high-risk patients with analytics and risk tools has been a high focus. The interventions that can impact readmissions has received a great deal of attention. The communication of these high-risk patients to providers and the ongoing assessment of readmission calls, because we haven't eliminated readmission and we still have a great deal of opportunity for improvement. On the analytics front, we internally refer to our efforts as PCP-CS, or Patient-Centered Point of Care with Clinical Decision Support. This spans much further than readmissions, but I'll just highlight it's the learning collaborative. This is the learning from the practice of healthcare, and a group is focused on opportunities. We have the clinical practice where it's applied, and we measure the effectiveness. And then we have the analytics component. So the PCP-CS is the intersection of these 3 areas. As we talk about our analytics within CHS and how it comes into this equation, we describe it at each touch point, we have the opportunity to deliver value to our patients. And the Curve 2 value is going to be measured by our patients' experiences. It's going to be measured in population health, and it's going to be measured at the cost of care. So you can see some of the components that we put into this equation. But the result is, are we delivering personalized care value? So as we started down that journey, like any good project, we had a vision, and I won't read through the vision. It's in your slide deck. But as we think about patient risk assessment and readmissions, I'm going to focus on some of the future state. The historical is the same way we've all done readmissions management in the past. So let's look at the future state. So what we would like to have is something that's done prior to seeing the patient. So our care managers basically can focus their work and their work flow the most efficient manner. We want the risk assessed from a predictive model that basically takes into account more variables repeatedly than most of our case managers might be taking into account. And we want that to be pulled from our electronic medical record system because that's the source of a great deal of clinical information that we've collected. And then we also have some other sources of data that come into play in that risk model. And we would like it to, for automation to automatically come into play for this. We like it calculated for the risk managers. We're not going to ask them to do the calculations. And we'd like for it to update because as the case managers practice, we would like to reflect the change in risk. So in our case, we set a goal of we would like this to update and reflect the progress hourly. And for the care interventions, we would like some recommendations to be assigned automatically from the algorithms, and we'd like to measure the efficacy of these interventions because this is an evolving process, and we have opportunities to put new interventions in where we see one that may not be making the progress that we anticipate. So behind the scenes, we have the risk model. Our analytics group internally is known as Dixon Advanced Analytics. That's a team that we formed a couple of years ago, just focused on our corporate analytics. They ran over 2 years worth of readmission modeling, and they came up with a risk model that has about a 79% accuracy rate for general readmissions. And compared to literature, this is a very high accuracy rate. So we've refined it over 2 years of historical, and we've refined it further over the past year of practice, and we'll be continuing to evolve it going forward. The heart of it, like most risk models, are to divide our patients into segment models. So on the screen, you can see some of the models. The most significant point here is, once again, we want to focus the case managers on the higher risk patients. And in some cases, we can identify patient populations that have extremely low risk of readmissions, and we would then reduce some of the effort that we might otherwise spend on those patients if we didn't already have the risk analytics in place. So in terms of how this works in practice, we're able to predict the patient's individual risk for a 30-day unplanned readmission. And with our Canopy, that's our internal name for our electronic medical record, and our enterprise data warehouse, we have data sources pulling 40 predictive fields hourly for the risk score, and 15 other fields that we pull hourly that are operational metrics that come in. As this is applied, you can see the high risk group has quite a bit of higher risk of readmissions as they are presented to the hospital. So that's almost a 19% readmission rate predicted on a high-risk patient. And then you can see in the low-risk population, it's typically something in the 5% and less. So for some current stats on our readmission analytics, we fully deployed the analytics to our core hospitals in Q3 of 2013. So far, we've run 65,000 plus patients through this for their risk model analytics applied hourly. And in the case managers, we have 97,000 plus interventions that have occurred based upon the evidence of the risk model. And we have 208 case managers actively using this tool in our hospitals. And the screenshot at the bottom is literally a screenshot of the tool that they click into for doing this, for seeing their patient list, seeing the risk scores, seeing the list of potential interventions, and the potential impact of those interventions. So several key points about analytics and readmissions. Our analytics model is accurately identifying the patients with low or high risk, and our case management teams are able to focus their resources on the right patients, and we're improving our interventions to best fit the patients. Now, impacting readmissions requires interventions, collaboration, and a team approach. The analytics do not deliver a reduction in readmissions automatically. So we're refining those interventions over time. The slide on the screen shows some of our historical readmission trends. These are not one specific hospital. These are all the hospitals within our Carolinas healthcare system family aggregated. So we have some hospitals that have exceptional readmission reduction over the past couple of years. We have some hospitals that have opportunities. And then in aggregate, you can see where we're landing. This is compared against some of the predictive models that Premier provides us for their predicted readmissions. As just an example, one of the areas of this focus has been readmissions in heart failure. We introduced one program within our healthcare system called Heart Success in 2013. And the components of this are very similar to the other initiatives that we bring into play as we talk about transitions in particular. The key components, the risk assessment, the transition clinic, one of the things that we brought to bear, the co-management of the patient with the primary care provider, our telehealth, which is our call center and electronic interaction, and then remote patient monitoring when needed. For the CHF example, this led to a 3.5% reduction last year, and it is improving. And this slide just shows the CHF reduction over our expected over the past few years. So some of the other resources that we use to tackle readmissions, one of the key elements is customer relationship management, because beyond the electronic medical record, there are those patient encounters that I mentioned at the beginning, the 11 million in our healthcare system. And those are not all hospital-based. That's the visits to the primary care. It's as you pass through rehab, as you move through post-acute, or as we refer to it as continuing care, as you call the nurse triage line. These are all examples of an encounter. So a few elements that we brought into the CRM initiative was just the discharge call management. Traditionally, that had been done in a separate system, but we didn't have that tied back to the patient in a way that we could follow that. So by bringing this into the CRM solution, we were able to collect that information and make it a more valuable call. Part of the focus of that team that does the discharge calls is the transitional care management. So these are the patients brought into the CRM system that have been flagged as higher risk for readmission. So these are for interventions after they've left the hospital. This might be the follow-up telephone call, and those telephone calls can be at different periods of time and frequency based upon the risk. And this is interfaced back to our analytics so that we can continue to measure this and forecast this going forward. Another inpatient element of this is patient education. Patient education is one of the key areas of one of the interventions, or quite a few of the interventions. So this is interfaced back to our electronic medical record for tracking so that it's charted that the patient has completed an education module, and this figures back into the analytic hourly recalculation of a risk model score. And then another element is to fully leverage our clinical call center, and internally we refer to that group as telehealth solutions, because they have the 24/7 access, and they are integrated with our acute, specialty, primary care, and continuing care. And they're fully able to book appointments, connect someone with an education. They're able to connect someone with a primary care provider. They're certainly now a key element of both our hospital care as well as our care as you leave our facilities. And then one of the tools that's becoming more important to us, but we're still evolving, is the advantage of having a patient portal. In our case, we call it My Carolinas, and that's just our patient web and mobile solution for accessing our healthcare services. Thinking in terms of next steps and some of the current activities this year and next year, we've got to continue to refine our interventions and personalized solutions. And we have to figure out how to continue to spread this across our enterprise. We have great pilot programs that have demonstrated significant improvement. But with an organization of our size and all the locations that we provide services, our challenge is the spread across the enterprise. And we also need to continue to develop new interventions that match personalized models. So, for example, one element that is coming into play is shared decision-making in the form of the patient participating in what is a solution that would generate the best outcome. When the patient participates in that, we get better results. Another element here is to enhance our view of the patients through these care transitions. So the ability for us to continue to track and get a more rich data subset to do analytics on is essential. So as you touch our organization through any form, or even our partners who participate in the care, then we need to get that data and we need to tie it together through our analytics. And then we're focusing increasingly on population health, and the solutions that are going to be required for that involve some new tools over time. So we're identifying what are those tools, what can we automate, and how can we bring clinical decision support to bear for this. And then leveraging the virtual visit and online patient engagement initiatives. This is once again a key driver. A lot of the meaningful use stage 2 emphasis brings this to the attention. But there's a lot of new opportunities to apply the technology and explore some opportunities other than telephone type of interaction with a patient. And some of this will be some innovative new ideas. And as I said, innovate with new strategies, new technologies, experiment, learn, and continue to evolve our program. And that's pretty much where we're headed. So, Anthony, at this point, I'll kick it back to you.
Very good. Well, thank you very much, Dwayne. Looking forward to our Q&A in a few minutes. But now we're going to hear from our sponsor, represented by Deborah Bulger, VP of Product Marketing with McKesson. Deb?
Thank you. Good morning. Can you hear me okay?
You sound great.
Perfect. Well, I really appreciate the opportunity to participate and certainly to sponsor this presentation. I think that we all know the challenges of the cost of readmissions, and depending on which study you look at, I think Dwayne cited a $15 billion cost. Knee-High cites a $25 billion. It really doesn't matter. That becomes rounding error when you start thinking about the billions of dollars that drive waste and certainly drive the need and drive higher cost in healthcare. And I think Dwayne summarized it extremely, extremely well. If we look at readmission management, the challenge sometimes of readmission management and the readmission reduction is that it can cost the prevention can cost more sometimes than the financial benefits or incentives or the loss of, or the penalties that you might incur, or the loss of volume in your fee-for-service business. And I think what Dwayne described was a methodology of making this is part of your workflow. This is part of, driving analytics into your workflow and making that information happen in real time as you start managing these patients. So, Dwayne, congratulations. You all have seen phenomenal results, and I commend you for that effort. And I know it's not easy. Analytics is not always easy, but you've done a great job with that. So I think if we were going to summarize on from a McKesson perspective, we would follow almost exactly that same path. There's the concept of risk reduction while the patient is in the facility, and you have an opportunity to find out and identify those high-risk patients with the tools that Dwayne has described, to be able to give you that information, and then take a multidisciplinary approach to assessing those patients and communicating that risk to the caregivers and case managers while that patient's still in the hospital. We use tools or provide tools that create a visual display of risk in our visibility products, for example, where we can flag a patient on a visual display that says this patient has criteria that could be at risk, so that kind of information can be very visible to the caregivers, and caregivers can then act upon that. The second phase that we look at is the care transition, so making sure that you have activities in place to help transition that patient to the next level of care. Things like discharge instructions, follow-up appointments, medication reconciliation, tools that can live within your EHR, but also tools that can communicate out to transmit that information to the primary caregivers. We look at our care management solutions as a way to start to communicate care during that care transition and provide a workflow and a path for those patients to become more self-sustaining as an outpatient and manage their outpatient care. The third piece of this is post-discharge. So we look at how we utilize tools to mitigate barriers to self-care, ensure those steps are taken to address patient compliance, social and educational needs. And then, again, that communication link to the post-acute caregivers, so home care, your payers, your telehealth center, your call center. We have tools for population health today that start to provide information to the physician in terms of gaps in care or needs for intervention. We also have tools that help predict the likelihood of hospitalization of those patients. So it's an adjunct to your in-house predictive models for readmissions, that ability to understand the likelihood that patient would be readmitted, and then the likelihood of the transition of their conditions. And then finally, we look at measurement. And so analytics at the beginning with predictive and prescriptive analytics is absolutely key while the patient's in the hospital. On the retrospective side, we help our hospitals understand what was the cost of the readmission and what was the benefit of that reduction in terms of dollars saved, lives saved, patient satisfaction, all of those things that you want to monitor. There are many contributing factors to readmissions, so you want to be able to understand the financial and quality implications of those, measure, monitor, look for improvement opportunities. And what I really liked, Dwayne, about the things you talked about was the resources in your organizations are precious and hard to get, and so you want to focus your efforts on those high-risk patients and the patients where you can have the greatest amount of impact instead of trying to support 100% of those. It doesn't mean you ignore other patients. It just means that you put the resources on those patients who have the highest probabilities. And I think that's really key, and I think the tools that you use in analytics to help prescribe that and to monitor that will help you start to look at the value. We had one instance of an organization who found that even though it costs dollars for resources to put in care managers, case managers, and transition managers, the return on investment is about 4 to 1 in terms of reducing the readmissions and improving your population health. So thank you for giving me the opportunity to summarize and to talk a little about what we do at McKesson in support of these kinds of activities. And again, congratulations to Carolinas for the efforts. So I will turn this back over to you, Anthony.
All right. Very good, Deb. Thank you very much for that and sponsoring today. So now we're going to do our Q&A. We've got plenty of time, so As I mentioned, please type your questions into the Q&A box, leave the default set to all panelists, and send them in. So, Dwayne, first question for you from one of your CIO colleagues out there. You may have mentioned this already, but who actually developed the algorithm and the use of the 40-plus data elements to begin to predict high-risk readmissions? Is this algorithm something that could be shared? Thanks.
Well, I'll say that over time it will be shared. Our analytics team, I mentioned their name earlier, our Dixon Advanced Analytics team has invested a couple of years working on this. And the foundation for some of their work were published analytic risk models. But it does have some intellectual property that's part of the model. And I'd be happy to connect anyone with our analytics group, and they can certainly explain their methods and their processes. It's not intended to be a product as much as they've put a lot of thought into it, and they haven't published some of the aspects of this yet. But they talk to many organizations about what they're doing, and they definitely are quite willing to share the factors that they've identified as some of the most significant that they focused on. So they frequently present that.
Okay, so we'll handle that offline. See where that goes. Have you had any success with patient home monitoring and video-based physician or nurse consultation to reduce readmissions?
We have. We've had many years of some form of remote patient monitoring for example, CHF patients post-discharge, and significant reduction. And I think some of the earlier numbers were in the range of 22% reduction in readmissions. And we've done a number of pilots using some of the newer technology and a Beacon Grant initiative over the past couple of years. We had even deployed iPads to patient homes so that they could interact with their medical home through using some of the new technology, including video. And we had quite a bit of success with that in small pilots. Now, that technology hasn't evolved quite as fast as we would like so that we could fully deploy that, but we've identified populations that we think the opportunity exists for, and then the technology is kind of catching up with us. And I think that will be evolving very quickly over the next few months, because virtual care has been a focus of our healthcare system over the past year, and we'll be making a few announcements the next couple of months.
Very good. Has anyone looked at ED readmissions and the impact they have on inpatient readmission numbers?
I don't know the relationship between the two. I would say that's probably a better, that would be better addressed by our analytics group. So I think I'm going to take a pass on that one rather than making a guess.
No problem. Let's talk a little bit about the relationship that the IT department has to have with the clinical department when it comes to an initiative like reducing readmissions. One of the typical problems or conundrums in healthcare IT is that IT can't lead it, can't own it. It's got to be a business leader or a clinical leader, but can support it. So, from your perspective, Dwayne, how should the relationship work with the clinical heads when it comes to reducing readmissions?
Well, first of all, we have to be their partner, complete partner. We have to be in their meetings, in their planning, in their discussions, where they discuss what's working and what's not working. And I think IT is an enabling technology to address readmissions. There are a lot of things that we can do that will accelerate their progress or let them see if something is working or not working. Electronic dashboards that are driven off of real-time data so that they can measure and see the progress are essential. Being able to tie the patient together through a master person index and bringing data from all these disparate systems together, we can enable that, and and ensure the accuracy behind the scenes. So I think there's a lot that we can do, and there's so many other opportunities for integrating when we think about the clinical data, the social data sets, big data, and then ancillary systems. And I'll just give an example of traditionally we had a system that tracked customer complaints, patient complaints. We had a system that tracked and charted discharge calls. We had another system that was tracking, reach out to patient initiatives, and so on and so forth. As you talk about letting people sign up for education and classes, getting all this data in a form that we can see the relationship is essential. And then we bring this to bear, whether we're talking readmissions or length of stay, or we're talking patient navigation. We're really enabling some advances in care planning. So I think we're an enabler, and the analytics group in particular, which is not really part of IS, we support the analytics team, but I think we're essential there in being able to get this view of a large population, which is what we're trying to address within Carolinas HealthCare.
Very good. We know that one of the things that CIOs are really grappling with is the requirement under meaningful use that a certain amount of patients actually use the portal that you put out there. So you can't just put it out there and you're done. You have to get people to use it. And the big complaint is, well, how can we be responsible for that? But what are your thoughts around that? Under the guise of reducing readmissions, one of the big things is, hey, if you're engaging with the portal, if you're learning about your condition and your health, you're more likely not to come back, I would assume. So your thoughts around the role a portal can play and how folks can get patients to engage with it.
Well, like all major healthcare organizations in the country, we're working to gain the desired interaction with the portal, the patient engagement, and that's something that we're still tackling, to be honest. We're part of that's education. That's both for the caregiver as well as for the patient, while we have the opportunity to do some training or education on site. So if you're in the hospital, then some of the things, for example, are patient education that talks about the portal, signs them up for the portal, and tells them information and things that they can use the portal for post-discharge, for example. I'll give an example of something, though, that's kind of post-discharge that comes into play. And an example of that would be some of the resources that are community resources that would be appropriate for the patient for the challenges that they may have. This could, if we provide that type of information through the portal, then we get into a scenario that as they run into challenges, whether we're talking about transportation or we're talking about even other charity type of benefits or resources they could call upon, we need to provide that information, and it needs to be timely, updated, and then we can also use that as a method of communicating with the patient going forward. So I think there's opportunity there for it to be a recurring visit to the portal, but we have to create that rich experience.
Let's talk a little bit about different types of transitions of care when we're reducing readmissions to different care venues. You have someone being transitioned back home where they need engagement with their ambulatory physician. Could be long-term care. Sometimes it's a floor in the hospital that's being, rented out to a long-term care company. Sometimes it's a separate facility, a different company. Could be, home for hospice. Do you need to have different plans for different transitions of care as one way to slice and dice it, and then also by condition based on things that CMS is incentivizing you to reduce readmissions for? Does it need to be sliced and diced a number of ways?
It does, at least that's my opinion. I'll say that we have initiatives focused on many areas beyond which there's a penalty at this point in time, for example. But once again, once you identify the readmission opportunity that you're going to tackle, and skilled nursing is a great example. We have skilled nursing in long-term care that we own, but we also have to work with many skilled nursing facilities that we do not. So you have some strategies that have to come into play there in terms of the measurement and how you interact with them and build a working relationship. How do you measure that? And then how do you strategize about that going forward, if they're performing good or bad? In some cases, they may be, an external organization that we do not own may be outperforming one that we do, and we want to learn from them. So I think the strategies, this is not a case that one size fits all. You have to literally figure out the population, figure out the points through the continuum of care, and then you have to figure out what the challenges are, because they are different, even within that area of the continuum of care, like the skilled nursing example.
Well, you're obviously with one of the larger healthcare providers in the country. If you were able to scale it down in a sense and give advice to, 1, 2, 3 hospital health systems, what would your advice be in terms of the resources you can imagine they might have at their disposal? Any sort of maybe quick and easy list of how to approach this if you get a little more resource constrained?
I think, honestly, most of the solutions for dealing with readmissions are well known. It's transition planning if you're in the inpatient setting, the discharge education, coordination with the post-acute care is essential, and then the transitional care support. The real biggie there is the transitional care support, and I can tell you that we did a project that was very insightful to me, where we followed some patients through the discharge process, and they consented for us to participate in this, and we actually had members of our organization follow them even to their home, and just as observers. And I can tell you that introduced a lot of opportunity to it. And so there's the things that you think are happening, and then there's the scenarios that really do happen, and then that lets us identify how can we improve our processes.
Just as a final question, the things related to reducing readmissions that were put into place through meaningful use, do you feel that they've been helpful to and constructive elements of the program? Have they been on track with what they've done around patient engagement and reducing readmissions?
My opinion is they've contributed to the solution, because they have definitely focused our attention and our resources, and I can tell you that we're getting value out of the fact that many organizations around the country are all working on this at a similar time. So this is a great opportunity for us to find best practice, even in things such as patient engagement opportunities. And then how can we apply that quickly to our own group? So I think that there is value. I think otherwise it would have been, different organizations at different areas of the country moving at different times. And I think we're gaining value out of the national effort.
Very good. Well, thank you so much, Dwayne. It was a great presentation, a great Q&A. As I mentioned, you will receive an email when our archive recording is ready and a separate registration is required. I want to thank Deb for speaking today and McKesson for sponsoring. Don't forget, for those who have the Chime CHCIO credential, attending our webinars gets you 1 CEU for each event. If you've asked us to contact Chime on your behalf, we will. If not, don't forget to contact Chime on your own behalf. Questions, comments, email me. Always interested in making these the best they can be. And go to our website to view our upcoming schedule and the last 12 months of archived events. So with that, I again want to thank Dwayne and Deb, and everybody have a wonderful day. Thank you.